Cardiology, baby, some cardiac pharmacology. Let's get right into this. So, anginal therapy. The objective of anginal therapy would always be to decrease myocardial oxygen demand. Demand or consumption, and or increase coronary blood flow. Those are obvious, but I'm stating them anyway. This can be achieved by a couple ways. 4, as a matter of fact. Number 1, decrease the heart rate. Number 2, decrease the contractility. Number 3, decrease the preload. Number 4, decrease the afterload. By decreasing the preload, you may help relieve signs and symptoms of angina due to volume overload. Like a great example of that's congestive heart failure. So by improving the myocardial stretch potential on the Starling curve is why we're doing that. Note, preload or end diastolic volume, in turn, usually you can use those, but not always. But it usually correlates with end diastolic pressure. Okay, let's not even get into the volume versus pressure thing, but so note the preload or end diastolic volume, EDV, in turn usually, but not always, correlates with end diastolic pressure. Now, to reduce afterload, that's the mean arterial pressure, which is proportional to what? The total peripheral resistance. So, that is the summary of anginal therapy. So let's talk about each one of the things now, the drugs that we use to do this with. So nitrates, notably nitroglycerin, and isorbide dinitrate. Isorbide dinitrate. How these babies work is they increase nitric oxide in vascular smooth muscle. Smooth muscle, which in turn leads to an increase in what? Cyclic GMP, which in turn causes smooth muscle what? Relaxation. Very good. Which therefore leads to a dilation of veins, where 60% of your blood is stored, and therefore even more so arteries. Most nitrates have a much more potent vasodilatory effect on veins than arteries, so that's why I put the little double asterisk here. And it is in the most important anti-anginal effect of a nitrate would be what? You tell me. Think about this now. The most important anti-anginal effect of everything we've talked about that a nitrate would do would be what? Decrease that preload. Decrease the preload on the heart. If you don't remember anything else about nitrates, remember that. You're decreasing the preload on the heart, right? Okay. Because of a decrease in afterload, which is the mean arterial pressure, which is proportional to the total peripheral resistance, you'll get a reflex increase in heart rate response to peripheral vasodilation, known as a reflex tachycardia. These also dilate the coronary arteries. The decrease in myocardial stretch or preload allows for increased coronary blood flow through the uncongested myocytes. Now, when does the coronaries fill? During systole or diastole? That's right, diastole. That's why we want to slow the heart rate down. You also have a decrease in MVO2, which is oxygen consumption. oxygen consumption. And a decrease in myocardial stretch tension or prelead will decrease the end diastolic pressure, thereby decreasing the myocardial demand and oxygen consumption. So that's nitrates in a nutshell for you. So let's go on to beta blockers. Beta blockers, what do? You block, what are you blocking? Beta 1 receptors. That's what they do. They block beta 1 receptors. And it is most important anti-anginal effect would be what? Decreasing afterload. If you don't remember anything else, remember that. With beta blockers, you decrease the afterload. You decrease the heart rate. You decrease the AV node. Conduction velocity. And you also decrease the contractility. Alright, so improved ventricular relaxation leads to improved ventricular filling like we've talked about. So guess what? We get an increase in ejection fraction now. An increased ejection fraction. Oh shit. Not EJ. Ejection fraction, I'm sorry. And a decrease in end-systolic volume. That's huge. Both of those. Increased ejection fraction and a decrease in end-systolic volume. Therefore, you also get a decreased renin release, right? So follow me here. If you get a decreased renin release, what's going to happen to angiotensin 2? It's going to decrease. Angiotensin 2, we know, is a potent vasoconstrictor. As a matter of fact, it's the most potent vasoconstrictor known to man. So what is that going to do? That is going to highly decrease your afterload. You get that decreased renin release, that decreased angiotensin 2, and you get a decreased afterload, baby. A decreased afterload, big time, which means you get a decrease in mean arterial blood pressure. Decrease in mean arterial blood pressure, which leads to an increased ejection fraction. And despite the decrease in contractility, because the decrease in afterload is a stronger effect than the decrease in contractility. So the decreased MVO2 is secondary to the decreased afterload, the decreased heart rate, and the decreased contractility. And that takes us into calcium channel blockers. Calcium channel blockers are coronary artery vasodilation, which counteracts vasospasm, thought to cause Prinzmetal's angina or Prinzmetal angina. Prinzmetal angina. So, calcium channel blockers are coronary artery vasodilators. Coronary artery vasodilators, which counteracts the vasospasm thought to cause Prinzmetal angina. Now, other forms of angina are treated by altering preload, afterload, or an O2 demand. The prevention of coronary vasospasm is key to treatment of Prinzmetal angina. So that's why calcium channel blockers are so important in this. Note, however, that none of these medications decrease the progression of coronary artery disease. Okay? So the treatment of patients with coronary artery disease should rely on the prevention of acute coronary syndromes. Okay? Using such things as aspirin for antiplatelet effects or statin drugs for lipid lowering effects, etc., etc. So those are your anginal therapies. So let's talk about your antihypertensive drugs. We have the ACE inhibitors and the ARBs, baby. So the ACE inhibitors will all end in pril. pril, like benzapril, captopril, enalapril, lisinopril, rampapril, etc. Now, their mechanism of action, which they love on the boards to ask about mechanism of action. What's the mechanism? What's the mechanism? What's the mechanism? So, whenever I can give you a mechanism of action of a drug or of a pathology or pathophysiology, I'm going to just put it over and over and try and put it in your head. So, the mechanism of action of ACE inhibitors is it inhibits the conversion of angiotensin 1 to 2, angiotensin 2. Normally, ACE breaks down bradykinin. Bradykinin. Bradykinin there, he don't like that. But ACE inhibitors will increase bradykinin levels. Okay, so some side effects that you may have impaired bradykinin metabolism by ACE, leading to increased bradykinin levels, which is going to lead to a dry cough and angioedema. Decreased angiotensin 2 levels leads to a decreased aldosterone release. So how could that affect an EKG? Well, that could lead to hyperkalemia, couldn't it? See how we're tying it all in? Hyperkalemia due to decreased aldosterone release from A2. Now, a decreased A2, you also have less constriction of your efferent arterioles, so that is going to lower GFR. That's going to lower GFR up to 30% roughly. That's a lot, up to 30%. And an increase in serum creatinine is expected in most patients within 2 to 5 days of initiating ACE inhibitor therapy. Note, ACE inhibitors can precipitate acute renal failure in patients who depend on efferent arterial or vasoconstriction to maintain their GFR. Like a great example of that's in hypovolemia, decompensated heart failure, renal artery stenosis, chronic kidney disease. So you got to be real careful with ACE inhibitors. It's not, everybody thinks it's just a miracle drug. Oh, we give all diabetics ACE inhibitors, or we give anybody ACE inhibitor that has a problem. No, you got to be real careful with that. So just keep that in mind. Also, some other side effects are taste disturbances. They get a metallic taste in their mouth. They get a rash. It can cross the placenta, so it's fetopathic. You get a headache, fatigue, nausea. ACE inhibitors are not commonly associated with orthostatic hypotension, contrary to popular belief. So that's ACE inhibitors in a nutshell for you. So what about the angiotensin 2 receptor blockers, the ARBs? They all end in sartan. Sartan. Like azilsartan. Actually, I'll write a few in there for you. Why not? As soon as my computer cooperates with me. Azilsartan, candesartan, eprosartan, losartan. Remember that guy. And valsartan. So you get the point. Now, what is the mechanism? The mechanism of action of how these drugs work is in their names. They block the activation of angiotensin 2 receptors. Now, angiotensin 2 receptor inhibitors are not associated with a cough side effect. That's a big thing to remember there. No cough side effect. That's why a lot of people choose these over ACE inhibitors, even though ACE inhibitors are a tremendously wonderful drug for the right patient. There's no cough side effect at all with the ARBs. So let's because they do not affect the metabolism of bradykinin by ACE. In contrast, ACE inhibitors prevent the breakdown of bradykinin, and therefore the resulting increase in bradykinin has been implicated as the cause of ACE inhibitor induced coughing. So there's a couple, besides it crossing the placenta and being a teratogenic, what else could you tell me about as a side effect of ARBs in terms of the EKG? Well, hyperkalemia. So we'll see some peak T waves, right? Hyperkalemia. You don't have A2, you're probably blocking some type of receptor that aldosterone is working at as well. So that takes us into the diuretics. We have the thiazide diuretics, loop diuretics, and potassium-sparing diuretics. So the thiazide diuretics are hydrochlorothiazide, and chlorothiazide. Or chlorothiazide. Chlorothiazide. Now, the mechanism. Let's talk about that. The mechanism of action of how these guys work is they inhibit the sodium-calcium reabsorption. In the distal tubule. Some side effects of thiazide diuretics. We have decreased serum levels of potassium. We have decreased serum levels of sodium. We have decreased serum levels of H+, so we get a metabolic alkalosis. So we have an increased bicarb, right? Now we have increased serum levels of glucose. So that could lead to diabetes. We have increased levels of lipids. We have increased levels of uric acid. It's going to really piss off some gout patients. And we're going to also have the calcium sparing, so we're going to have an increased calcium level. Remember that one. So are you going to be more or less likely to depolarize on a thiazide diuretic? Less likely, right? So you're going to be, would you be more likely to get constipated or have diarrhea on a thiazide diuretic? Constipated, right? The GI tract slowing down. Very good. Very good. Loop diuretics. So the loop diuretics, we have two groups. We have the sulfa derivatives and non-sulfa derivatives. The sulfa derivatives are furosemide, and bumetanide. Furosemide and bumetanide are your sulfa derived. Non-sulfa derived is ethacrenic acid. Ethacrenic acid. He's a special one. Ethacrenic acid is not a sulfonamide, but it can be used in patients with sulfur allergies. So remember that ethacrenic acid. Now, the mechanism of action of how loop diuretics works is they inhibit the sodium-potassium chloride co-transport in the thick ascending limb of the loop of the Henle. Mechanism of action. They inhibit the sodium potassium 2 chloride transporter. In the what part? That's right, thick ascending loop of Henle. Now, that also promotes production of prostaglandins. So what's important about that? Well, that's promoting natriusis. Efficacy may be reduced with concurrent administration of an NSAID because of an NSAID-induced prostaglandin inhibition. So see, that's why you need to know that. Now, some side effects of loop diuretics include ototoxicity, and nephritis. Now, you're going to have some decreased serum levels of potassium, calcium, and hydrogen. So you're going to get a metabolic alkalosis. Now you're going to have increased serum levels of, what do you think? Uric acid. So again, you're going to precipitate gout and piss off the people with gout. So that's loop diuretics for you. So what do we got left? Potassium-sparing diuretics. So potassium-sparing diuretics here. What are a couple drugs that are potassium-sparing diuretics? Well, we have aldosterone receptor antagonists and spironolactone. And epirone. I've seen a question on this one. They got me with this guy because I didn't recognize the drug. Epirone. That's an aldosterone receptor antagonist, just like spironolactone. And then you have another way that's a potassium-sparing diuretic is a sodium channel blocker like triamterene. And also amiloride. Now, let's write that in there, what they are. The difference in them. So aldosterone receptor antagonist is spironolactone and epirone. So spironolactone and epirone are aldosterone receptor antagonists. And then you have sodium channel blockers. Number one, aldosterone receptor antagonist, which blocks the aldosterone receptor, which limits transcription and translation of new sodium channels on principal cells in the collecting ducts, which then leads to a decreased reuptake of sodium, which leads to a decreased efflux of potassium into the urine. Example of that would be spironolactone, a relatively nonspecific aldosterone receptor antagonist, or epirone, which is relatively specific for the aldosterone receptor, and it's an antagonist as well. So there's a decreased incidence of anti-androgen side effects like gynecomastia compared to spironolactone. So that's why people prefer epirone. With the sodium channel blockers, the potassium-sparing diuretics, they block the luminal sodium channel in the distal renal tubule. Okay, and that leads to a decreased reuptake of sodium and a decreased efflux of potassium into the urine. And like I said, triamterene and amiloride are those two. So what is their MOA, baby? Spironolactone, apirolone, triamterene, and amiloride, they decrease the reabsorption of sodium. Decrease reabsorption of sodium, decrease the efflux of potassium into the urine. So potassium is spared from the urine and retained in the body. So an overdose or a super therapeutic levels of potassium sparing diuretics can lead to what? Hyperkalemia. Hyperkalemia we have to be concerned about versus the loops and the thiazides, which cause what? Both of these babies. What do you think? So if hyperkalemia is caused by potassium sparing diuretics, well, the thiazides and the loops would be, you see hypokalemia with these guys. Hypokalemia with these guys, but you see hyper with potassium sparing diuretics, as you would expect potassium sparing. So that's your diuretics in a nutshell. Well, actually note that normally to maintain ionic charge balance, you have an influx of sodium from the distal tubule lumen into the principal cells. Then you have, that leads to an efflux of potassium from the principal cells into the urine in the distal tubule lumen. Thus, blocking the luminal sodium channel in the distal tubule prevents efflux of potassium into the urine, thereby retaining potassium in the body. When significant diuresis is necessary, loops and or thiazides are first-line agents. Although relatively weak in terms of their diuretic effect, potassium-sparing diuretics are commonly co-administered with loops or with thiazides to dampen the potassium-wasting effect of these more powerful diuretics. So that is the purpose of the loop diuretic. Moving right along to the sympatholytics, beta blockers, clonidine, methyl-dopa, hexamethonium, risperidone, and prazosin. So let's dive right into these babies. What do we know about beta blockers? Well, they decrease renin release. If you decrease renin release, you're going to do what? You're going to decrease eventually angiotensin 2. Which is a potent vasoconstrictor, right? So they block the heart beta 1. Beta 1 inotropism. And a decreased cardiac output. Now, what's the side effects of some beta blockers? Well, some side effects include asthma like in pulmonary or beta 2 pulmonary vasodilation blockade, bradycardia, AV block, CHF, impotence, and sedation. All right. So what about clonidine methyl-dopa? What do we know about this guy? We always got to go with that mechanism, right? The MOA. They are central alpha-2 agonists. Central alpha-2 agonist. It acts in the vasomotor center of the medulla to decrease presynaptic norepinephrine release. Decrease norepinephrine release. Let me repeat that. It acts in the vasomotor center of the medulla to decrease the presynaptic, remember norepinephrine is made presynaptically, presynaptic norepinephrine release. So what would be some side effects from that? Can you think of any? Some side effects would be like sedation, dry mouth, rebound hypertension. That's a big one. Remember that one with the clonidine and the methyl-dopa, the rebound hypertension. Hexamethonium. Hexamethonium is a ganglionic blocker. He's a ganglionic blocker. He's acetylcholine antagonist. In autonomic ganglia. He is an acetylcholine antagonist in autonomic ganglia. So some side effects of this guy might be some parasympathetic and sympathetic stimuli that are blocked at the presynaptic or preganglionic site. So that could cause urinary retention, dry mouth, blurry vision, orthostatic hypertension, etc. Let's see here. So risperidone, what do we know about risperidone? Well, his mechanism is he blocks the VMAT, baby. He blocks the VMAT. He blocks the vesicular monoamine transporter, also known as the VMAT, which normally transports norepinephrine, serotonin, and dopamine into the presynaptic vesicles for release. Remember, we talked about norepinephrine being made presynaptically earlier. So what are some side effects of this guy? So side effects of risperidone include, you guessed it, depression, nasal congestion, nausea, hypotension, and bradycardia. Alright, and prazosin. What is prazosin? Isn't he that thing that works in the bladder? No, he is a selective alpha-1 receptor blockade. Receptor alpha-1 blockade. Remember, everything's mechanism these days. Receptor alpha-1 blockade. So this is important right here, and they like to test you on this. Okay, so some side effects. The big one, the one I want you to remember, orthostatic hypotension. Orthostatic hypertension, particularly after the first dose, okay? Okay, particularly after the first dose. So, as might be expected, you can get a reflex tachy. A headache and dizziness as well has been reported. And that is the sympatholytics. Let's go on to the vasodilatories, the vasodilators. We got hydralazine, calcium channel blockers, nitrates, and minoxidil. So hydralazine, mechanism of hydralazine. What are you? You vasodilate arterioles. That's cool, man. You vasodilate arterioles. Therefore, what are you doing? You're increasing cyclic GMP, aren't you? And therefore, you're ending up being a smooth muscle relaxant. Smooth muscle relaxant. Since it dilates arterioles more so than veins, there is a good bleep reduction, afterload reduction. It's dilating the arterioles more than the venous system. So instead of preload, it could only be preload or afterload. We are afterload reducing. Some side effects include lupus-like syndrome, lupus-like syndrome, reflex tachy, and angina. Good Lord, a lot of things with hydralazine. So calcium channel blockers. Well, we got two different types of calcium channel blockers to start off with. Let's get this out of the way here. Number one, you got the non-dihydropyridine calcium channel blockers. Number two, you have the dihydropyridine calcium channel blockers. Now, the non-dihydropyridine blockers are more specific for the heart. Again, the non-dihydropyridine calcium channel blockers are more specific for the heart. And those examples of that would be like verapamil, and diltiazem. Yeah, diltiazem, verapamil, diltiazem. Now, the dihydropyridine calcium channel blockers are the dipines. The dipines. They are more specific for blood vessels. So some examples of those would be like amlodipine, or nifedipine. So they're not, nifedipine is not heart specific, although it is a calcium channel blocker. So what is their mechanism of action? Mechanism. How do they work? What do they do? So calcium channel blockers, mechanism of action. Mechanism of action. There are voltage-dependent L-type calcium channels that are blocked by these bad boys. Voltage-dependent L-type calcium channels that become blocked. Therefore decreasing calcium influx. Which leads to an inhibition of cardiac and vascular smooth muscle contraction. which leads to what? This is important. Decreased, number one, a decreased myocardial contractility. Decreased myocardial contractility and a decrease or a vasodilation of systemic and coronary arteries. And therefore, when you do that, you end up with a decreased what? Total peripheral resistance and a decreased afterload. And that is the point of that. So what about the side effects of calcium channel blockers? There's got to be some. Well, with the let's actually write these in here on a new page here. So for the non-dihydropyridines, calcium channel blockers, such as, what were they again? Diltiazem and verapamil, that are more specific for the heart. You see cardiac depression. You also see nodal blocks. Now, for the dihydropyridine calcium channel blockers, you see these are the diapines like nifedipine and amlodipine. They're more specific for blood vessels, so their side effects include peripheral edema, as you might imagine. Peripheral edema, flushing, and dizziness. Both dihydropyridines and non-dihydropyridine calcium channel blockers. Here's what you need to know. Both cause these two side effects. Constipation and gingival hyperplasia. What other drug classically causes gingival hyperplasia that the boards love to play games and test you with all the time? That's right, phenytoin. Good job. So remember that gingival hyperplasia and constipation are what they're going to be looking for both the non-DHPs and the DHP calcium channel blockers. So let's go back and let's talk about minoxidil. Or no, we're just in the nitrates. My bad. Skipping a little ahead there. So some nitrates like nitroprusside, nitroglycerin. Everybody's heard of nitroglycerin. Isorbide dinitrate. Dinitrate. Now, what is their mechanism of action of a nitrate? The MOA of a nitrate. The mechanism of action of a nitrate is it forms nitric oxide. A free radical that activates guanylate cyclase. And then that increases cyclic GMP. in smooth muscle, and that in turn leads to vasodilation. And that's how nitrates work. So nitroglycerin is more specific for venous over arterial. You need to know that. So I'm going to write that in there for you. Now the nitroglycerin is more of a venous over an arterial dilator. And that is why people consider him, he decreases the preload to the heart, and decreases left ventricular end diastolic volume and left ventricular end diastolic pressure. And it increases coronary blood flow. By decreasing myocardial tension. You got it. Now nitroprusside, on the other hand, is an arterial over venous dilator. So what can you tell me about him already in terms of the heart dynamics and functions? He's an afterload reducer. Afterload reducer, right? So don't just think nitrates, oh, venodilators. No, some reduce preload, some reduce afterload. That's just how it is. So let's talk about some side effects of the good old nitrates. Obviously, postural hypotension, reflex tachycardia, right? We're dilating, right? So if we're dilating, we're going to get a reflex tachy, flushing, headache, methemoglobinemia, cyanide accumulation from nitroprusside. Now, tolerance can develop, so you treat with a drug holiday. That's how you treat it. So let's move on to minoxidil. Minoxidil's MOA is it hyperpolarizes vasculature or vascular smooth muscle by, how would it do that? Opening potassium channels. He opens potassium channels for people. Therefore, he lets the cell hyperpolarize. Side effects include pericardial effusion, reflex tachycardia. Hypertrichosis is very common, and that you need to have in there because that is a board question if I've ever seen one. They love to ask you about this for some reason. Haven't quite figured it out yet. Especially on boards too. This is all over boards too. So with minoxidil, you get hypertrichosis. Now, it's common, up to 80% of patients get it. Also, pulmonary edema, hyperglycemia, because why would with minoxidil, why would you get hyperglycemia? Because of the effect of the ATP-dependent calcium channels that needed to release insulin, maybe? There you go. Now, because minoxidil causes hypertrichosis, it is also marketed for hair growth as Rogaine. That is minoxidil for you. All right. Cardiac glycosides. I love them. Let's talk about them, baby. Digitalis, digoxin, and digitalis, digoxin, and digitoxin. Cardiac glycosides are used to treat congestive heart failure and cardiac arrhythmias. Congestive heart failure and cardiac arrhythmias. So digitalis. It inhibits the sodium-potassium ATPase. What else inhibits the sodium-potassium ATPase? Ischemia. Sounds good to me. Absolutely. Well, anyways, by inhibiting the sodium-potassium ATPase, it competes with the potassium for binding to the extracellular alpha subunit. Thus, hypokalemia would worsen or not worsen digitalis if you were toxic on it. Hypokalemia would worsen digitalis toxicity if you were toxic on dig. Therefore, you start to see yellow halos, etc. What happens is inhibition of the sodium-potassium ATPase increases intracellular sodium in myocytes, which indirectly slows down extrusion of calcium via the sodium-calcium pump. So you get an increased intracellular calcium. Now, the increased amount of stored calcium in the sarcoplasmic reticulum, thereby increasing the amount of calcium released by each subsequent action potential, so you get an increase in contractility. An increase in contractility. Example, increased force of contraction for a given preload, etc. It prolongs refractory period phase 4 in the AV node. It's called the vagal effect. The vagal effect is it prolongs, digitalis prolongs the refractory period, which is phase 4 in the AV node. Therefore, it reduces the number of impulses that reach the ventricles. Therefore, it reduces ventricular rate. Therefore, it's an antiarrhythmic effect. So that's why we do that. So what about digoxin? What do we know about him? Well, he's extracted from Digitalis lantana plant. Digitalis lantana plant. That's he binds to the extracellular alpha subunit of the sodium-potassium ATPase in myocytes, just like digitalis did. But he has a shorter half-life. Shorter half-life compared to digitoxin. He's eliminated by the kidney. So there is a longer half-life in patients with what? Kidney failure, right? So you got to watch people on digoxin with kidney failure. Now let's talk about digitoxin. Digitoxin is eliminated by the liver, just like digitalis. It's longer half-life of about 5 to 7 days. 5 to 7 days compared to digoxin. Its toxicity, because of a narrow therapeutic window, that's what this is due to. The toxicity of the cardiac glycosides includes the AV block, VTAC or fib, fibrillation, nausea, vomiting, diarrhea, blurry yellow halos, blurry yellow halos. Now the EKG changes include ST segment depression, T-wave inversion, scooping of the ST segment, scooping of the ST segment, decreased QT, and an increased PR interval. And an increased PR interval are not a sign of toxicity. Rather, it is expected and called the digitalis effect. Think you'll be tested on that? You betcha. The digitalis effects, it freaks a lot of people out when they see an increased PR interval. So like, oh, they got heart block, they got heart block. But that is not a sign of digitalis toxicity, because remember, the toxicity can cause an AV node block, right? It's called the digitalis effect to prolong the PR interval. So you need to know that. That is a board question. So, yeah, here we go. So some risk of toxicities increased by, number one, renal failure, only in which one of these? Digoxin, very good. Number two, hypokalemia, since digoxin competes with the potassium ions for the same binding site on the sodium-potassium ATPase. Now, here's one that might throw you. Hypomagnesemia. Sodium-potassium ATPase uses magnesium as a cofactor, right? There we go. Quinidine and amiodarone, right? Quinidine and amiodarone have a high risk of toxicity. Now, there's a combination therapy with calcium channel blockers, especially verapamil, that the risk of this goes up. Now, the antidote for the toxicity to digitalis can be remembered by the little antonym down here, LAMP. That's lidocaine, anti-dig fab fragments, or digibind, anti-dig fab fragments. Also magnesium to treat hypomagnesemia, and potassium to treat the hypokalemia. So the one I would remember is lidocaine and the digibind, or the anti-dig fab fragments. So that's your cardiac glycosides. All right, class 1 antiarrhythmics. The antiarrhythmic drugs, there's 4 classes of them, so let's talk about class 1. All can be it can all be pro-arrhythmic, okay? Even though these are antiarrhythmics, they can be pro-arrhythmic. I know it's kind of trippy, huh? So this is the action potential of the heart you're seeing here, this little thing right here. That's how the AV node usually conducts its electrical components. All go through that. So this, would be like where sodium rushes in the cell. We maintain threshold, and then we potassium rushes out right here, and then we're back to normal. So you can divide this into separate classes. Okay, you can basically let's get a new page and start with separate classes here for all these. So class 1 is all sodium channel blockers. Class 2 is beta blockers. Class 3 is potassium channel blockers. Class 4 is calcium channel blockers. So that right there is the big picture. You can remember that by some block potassium channels. Some block potassium channels. Sodium channel blocker, class 1. Class 2, beta blocker. Potassium channel blockers, class 3. Calcium channel blockers, class 4. So, very good. That's the big picture on the antiarrhythmics right there. So let's go back to the class 1 antiarrhythmics. What do we know about this guy? Well, there's 5 mechanisms and effects in common to class 1A, class 1B, and class 1C. Those are all our sodium channel blockers. All are sodium channel blockers. All are fast sodium channel dependent. All decrease slope of phase 4 depolarization. Number 4, all decrease the maximum rate of depolarization without changing the resting potential. Without changing the resting potential. And number 5, all raise the threshold for action potential firing to more positive potentials. All positive potentials. Hence why some of these antiarrhythmic agents are also used as anesthetics. Like example, that would be lidocaine. So now we have our class 1 antiarrhythmics. These are used for most atrial and ventricular arrhythmias. All right. So let's meet the drugs. The double quarter pounder, the DQP, disperamide, quinidine, and prokinamide. That was Vasodilators, disperamide, quinidine. Number 3, prokinamide. Prokinamide. Now, disoprudenine side effects, it's got some anticholinergic side effects to it. Let's write these in here. Some anticholinergic side effects. Also, hyperkalemia. And Coumadin increases its toxicity. So it's obviously hepatically excreted. Now, quinidine, the side effects of these are the 3 T's plus cardiac depression, thrombocytopenia, tinnitus, and torsades. Thrombocytopenia, tinnitus, torsades. Now, severe hypotension with cardiac arrest as well. Severe hypotension with quinidine with cardiac arrest. Now, the side effects of procainamide is you get a reversible systemic lupus-like syndrome. Lupus-like syndrome, like drug-induced lupus. And you also get agranulocytosis with procainamide. Now, the effects of Class 1A antiarrhythmics on the action potential and the EKG. Like all Class 1 agents, Class 1 antiarrhythmics block sodium channels. That's how they roll, baby. They block sodium channels. Block sodium channels. That's what they do. That's what they're here for. Block sodium channels, Sergeant. So, that slows the rate of depolarization, so it slows the upstroke of the action potential. And you see that right here. It slows the upstroke of the action potential. That's what you see right there. And it widens the QRS complex. You see that right here. So you get a widening of the QRS complex and a slowing of the upstroke of the action potential. Now, number two, unlike other Class 1 agents, Class 1 antiarrhythmics also non-specifically block potassium channels. Non-specifically block potassium channels. So this slows the rate of repolarization. So you're going to get an increased action potential duration, and you're going to get an increased refractory period, which is going to lead to an increased QT interval on the EKG. So that's Class 1 antiarrhythmics for you. Let's go to Class 2 antiarrhythmics, which are beta blockers. The Class 1B antiarrhythmics are used for the termination of ventricular tachycardias and prevention of ventricular fibrillation after cardioversion following an MI. Used for the termination of VTAC prevention of VFib after cardioversion. After cardioversion following an MI. Following an MI. Alright, so let's talk about the Class 1B or the Class 2 antiarrhythmic drugs. They are lidocaine, tokinamide, meloxicam, and phenytoin. These are your four drugs. You can remember that by lettuce, tomato, mayo, and pickles. Lidocaine, tokinamide, meloxicam, and phenytoin. Now, Lidocaine is a local anesthetic and it has some toxicity to it. Local anesthetic toxicity, including seizures and cardiovascular collapse. Let's see here. Now, phenytoin has a lot of drug interactions, and it is highly protein bound. The effects of class 1B antiarrhythmics is a decrease in action potential duration, number 2, no change in effective refractory period. So those are the two things you need to know for the beta blockers. There's a decrease in the action potential duration, right? So you see right here, it's a little bit slower. I didn't do that very good. So you see right here, it's a little bit slower, and there's no change in effective refractory period. That means that there's really, see this? It's on the same line, same line, same line, same line. It's just a little bit shorter. So that's class 2 antiarrhythmics. Now the class 3 antiarrhythmics, the calcium channel blockers. I'm sorry, I completely skipped out on one here. Sorry about that, guys. The class 1C antiarrhythmics. Class 1C antiarrhythmics. They're used for suppressing PVCs, preventricular contractions, but only in extreme circumstances. Class 1C agents are used only as a last resort. Last resort. Warning now, you do not use class 1C agents in patients with pre-existing ventricular tachycardias or those with previous MIs. Okay? You do not use class 1C antiarrhythmics in patients with pre-existing ventricular tachycardias and those with previous MIs. And that, my friends, is highly, highly, highly important. You do not use class 1C agents in patients with pre-existing ventricular tachycardias and those with previous MIs. That right there could save you a lot of money from getting sued one day. You do not use class 1C antiarrhythmics in patients with pre-existing tachycardias and those with previous MIs. Done deal. Alright, now let's talk about class 3 antiarrhythmics, potassium channel blocker. Alright, this is funny. You're going to have to excuse me here because this is supposed to be a class 1B antiarrhythmic, not a class 2 antiarrhythmic, which would be a beta blocker, And because I was just getting ready to talk about beta blockers is why I realized this. This is a class 1B. And this one right here that I have for class 3 antiarrhythmics, that is a class 1C. So don't pay attention to those pictures, but pay attention to everything else. So these are the right drugs for a class 1B antiarrhythmic, but it is, remember, class 1. So lidocaine, tokenamide, meloxicam, and phenytoin, those are class 1B antiarrhythmics. So now let's talk about actual beta blockers. I can't believe I did that. That's funny. Alright. So examples include propranolol, esmolol, metoprolol, and atenolol. There's a ton more, but as you can see, LOL, OLOL, 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 that's what you look for. And what these do is they are conventional beta blockers. So they decrease sympathetic activity to the heart. You might know what receptor they do that with. That's right, beta 1. Very good. Number 2, they decrease cyclic AMP, which makes sense. Cyclic AMP is sympathetic. Number 3, they decrease the slope of phase 4. They decrease the slope of phase 4. They are especially useful in the treatment of certain things. Does anybody know what that might be? They're super useful in treating supraventricular tachycardias. They are very good at treating those why would they be good at treating those? Since they decrease the conduction through the AV node. So let's talk about some side effects. Some side effects include bradycardia, AV block, CHF, impotence, bronchospasm, and glucose and lipid metabolisms are altered, such that you get high triglycerides, and low HDL. So it predisposes you for coronary artery disease, but also what would high triglycerides, what would that predispose you to? That's right, acute pancreatitis. Very good. And low HDL, you can't protect your heart. You need that good cholesterol around, right? So that is beta blockers for you. Now there's a little trick for beta blockers. If it's A through M, I don't even remember. It was a nice little trick though. The exceptions are L and C. Carbetalol and labetalol, they block both, but I think A through M is only for beta 1 selective, and N through Z is beta 2 selective. So there's a nice little trick with the beta blockers. So let's talk about the class 3 antiarrhythmics, which are calcium channel blockers, not this class 1C drawing. Such a waterhead. That's funny. Alright, so let's talk about these bad boys. They are calcium channel blockers, and we can go ahead and name a few of these off. That would be iso, or actually, start with sotalol. Sotalol, albuterol, beryllium, Alright, now can you tell me of those? Also, we have a few more. Hold on. Amiodarone and dofenitide. Dofentilide. Yeah, let's talk about which two of these cause torsades de pointes. Which of these two are responsible for causing torsades de pointes? That would be this guy and sotalol. Sotalol and albuterol both cause torsades. Torsades de pointes, which is no good. How do we treat torsades de pointes? There you go, mag sulfate. Very good. Now, beryllium is a proarrhythmic. Has a side effect. Amiodarone has tons of side effects. Dofenitide doesn't really have hardly any side effects, but the ones we're going to talk about for amiodarone we have to talk about. So pulmonary fibrosis is one. Photodermatitis. Hepatotoxicity. Hypo and hyperthyroidism. Corneal microdeposits. And remember to check the LFTs, the PFTs, and the TFTs when using amiodarone. So that's basically all of the big ones there. The ones I want you to remember is it's hepatotoxic, so you can connect it to a million things. Obviously, you're going to get photodermatitis and get into your pancreas, your skin, your cornea, your whatever. You're going to get pulmonary fibrosis. Can you think of any other drugs you get pulmonary fibrosis with? Amiodarone, bleomycin, busulfan. There you go. So the effects of a class 3 antiarrhythmic agent, calcium channel blocker, there are 4 of them. Number 1, get an increased action potential duration. Number 2, get an increased effective refractory period. Number 3, you get an increased QT interval. Number 4, there's no change in phase zero since potassium ions are not involved. So, an increased action potential duration, an increased effective refractory period, an increased QT interval, and no change in phase zero since potassium ions are involved. So what would this actually then look like if it was a class 3 antiarrhythmic? Switch color right here. It would look like this right here. It would follow perfectly. Then it would go just a little bit out. Won't go any higher. Then we'll go a little bit above. Just a little bit. Just a little bit. And then it would go out. A little bit farther. A little bit farther. And then it would meet right back up to the middle. That's what a class 3 antiarrhythmic potassium channel blocker would look like if you were to draw it out on the ventricular action potential. So, class 4 antiarrhythmics, which we just pretty much talked about, or that was, no, we talked about class 3, I'm sorry. Jeez, I'm losing my mind. Class 4 antiarrhythmic. Class 4 antiarrhythmics are calcium channel blockers. So, two examples of that would be like diltiazem. Diltiazem, verapamil, etc., which exert their antiarrhythmic effect mainly by slowing the AV node conduction by inhibiting calcium influx. So additional effects of class 4 agents include, number 1, decreased SA AV node automaticity. Increase effective refractory period. And increase the PR interval. Alright, so calcium channel blocker toxicity. So when we're talking about toxicity, CHF is 1. Congestive heart failure is 1. You're blocking calcium channels, which is what the atrium uses to depolarize. AV node block, another one. Number 3, facial flushing. Facial flushing, headache, and gingival hyperplasia. Gingival hyperplasia. Take note of that. What other drug causes us to do that? Gingival hyperplasia. Phenytoin, you got it. Good job. Phenytoin. So, congestive heart failure. So let's talk about congestive heart failure therapy. And we could talk all day on CHF, but we're not going to get too involved in it because I think you pretty much understand it, but we'll go over it a little bit. Congestive heart failure results from the heart's inability to maintain the circulatory output in the face of the demand by the rest of the body. As a result of the decreased cardiac output, the RAS, or the renin-angiotensin system, is activated as well as the sympathetic nervous system. This leads to a systemic vasoconstriction, and a fluid retention. So we got two things working here that really Well, they have to work to compensate, but you really don't want them working, and that's the sympathetic nervous system and the RAS system working at once. The severity of CHF is organized in the New York Heart Association classifications, and that's New York Heart Association classifications. So there's like a class 1, 2, 3, and 4. Now, the class 1 symptoms occur only with vigorous activity. It's usually asymptomatic. Class 2, they say symptoms occur with prolonged moderate exercise, so this slightly limits their activity. Now, class 3 is when symptoms occur with usual daily activities of living, so the patient is markedly limited. So class 3 is when they really get into congestive heart failure. And class 4 is symptoms occur while the patient is at rest. They're not even doing nothing. So that's how the New York Heart Association classifies congestive heart failure. Now, the treatment decisions can be made by using the New York Heart Association's classification scheme. Class 1, what you would do is sodium restriction. Sodium restriction, loop diuretic, furosemide to achieve volume control, that'd be fine, and an ACE inhibitor or an ARB. Now, class 2 protocol is just you add a beta blocker. Class 3, this is moderate to severe CHF. Now, class 1 was just mild CHF. Class 2 was mild to moderate CHF, and class 3 treatment is moderate to severe CHF. So this one, you add digoxin. So when you see somebody in CHF on digoxin, they're in the last stages of heart failure. So you add digoxin for symptomatic relief. There's no improvement in mortality for this. And you also add spironolactone can also be added for class 3. For class 3. 4, as it has been shown to improve mortality in these patients. Now, African American patients have also been found to benefit from hydralazine plus nitrates. Hydralazine plus nitrates. Hydralazine plus nitrates. So let's go over a basic, if just a general, if you're attending and ask you how do you treat CHF, I want you just to have a general understanding of it as opposed to everything we just talked about, because that's kind of detail oriented and you won't remember it anyway. So the basic treatment for CHF. Number 1, put them on an ACE inhibitor. Or ARB. Number 2, beta blockers. Number 3, diuretics. Furosemide, hydrochlorothiazide, also digoxin. Number 4, spironolactone. And that is the NYHA class 3 and 4, where you add the spironolactone. Remember, it's mostly in 3 for potassium sparing purposes. But that's the basic treatment for CHF. The big one and the really important one that's been shown to decrease a lot of morbidity and mortality is the ACE inhibitor. ACE inhibitor is a great drug. And that takes us into hypolipidemic drugs. So we have statins, fibrates, niacin, resins, which are bile acid sequestrants, and ezetimibe. And all right, so let's start with the statins in order of descending potency, and we'll get a new page for these guys. Starting with the statins, rovastatin, rosuvastatin, I guess is the most potent, and then comes atorvastatin, and then you got simvastatin, and then you got lovastatin, pravastatin, and then you got fluvastatin. So rosuvastatin is the most potent, fluvastatin is the least potent. Now, the mechanism by which the statins work is they inhibit HMG-CoA reductase. They inhibit HMG-CoA reductase, the rate-limiting enzyme in the mevalonate pathway of cholesterol synthesis. So you get an increased production of LDL receptors. Increased production of LDL receptors. So, okay, I thought LDL was bad cholesterol. Well, that's why we're going to lower the LDLs, because we're increasing the production of cholesterol. So you're going to see a marked decrease in LDL, marked decrease. You're going to see an increase, a slight increase in the HDL. It's a minimal effect, but it still works. Number 3, you're going to see somewhat of a decrease in your triglycerides. Now the side effects. Side effects include myositis. Myositis, big time. You're going to have also increased LFTs, liver function tests. Example, you're going to have increased serum levels of liver enzymes like AST, ALT. You can also get drug-induced photosensitivity. Drug-induced photosensitivity. The FDA consumer update in 2012 said routine measurements of LFTs is no longer necessary, though. Statins may increase the risk of hyperglycemia in diabetes type 2, and statins may also cause cognitive impairment such as memory loss or confusion. But that is the statins for you, and the big one that they like to go for on the boards is the myositis, because statins are extremely fat soluble. HMG-CoA reductase is it's working the most at about 7 or 8 o'clock at night. Most people take statins in the morning, even though they're supposed to take them at night. It's the one drug you really are supposed to take at night. It's a statin, and it gets into their muscles, and it causes, a little bit of somewhat of rhabdomyolysis. That's acidic, so it can be toxic to the kidney. and therefore we can have a little kidney damage, some acute renal tubular necrosis, or whatever, and then it just leads to all types of problems. So that's the statins for you. But all right, so the fibrates. Let's get us a new page for those guys. The fibrates. The fibrates are gemfibrozil, and fenofibrate. These are the fibrates. All right. So what is they MOA? What's their mechanism of action? They activate a nuclear transcription factor, PPAR alpha. He's a nuclear transcription factor. So what happens is you get an upregulation of lipoprotein lipase. Which gives you an increased clearance of triglyceride-rich lipoproteins. And therefore, your LDL will do what? Decrease. Your HDL will increase, and your triglycerides are going to do what? Go extremely far down. Triglycerides go extremely far down. So if you remember with the statins, what did they do? They took the LDL way down, but they minimally took the triglycerides down. With the fibrates, we are really taking down the triglycerides. So let's talk about some side effects. As you might expect, myositis. This tells you the same thing as the statins. It's a fat-soluble drug. Fibrates are especially myotoxic when used in combination with a statin. Myotoxicity of a statin plus a fibrate is worse than the myotoxicity of exenatide plus a statin. Also, fibrates combined with statins may lead to rhabdomyolysis, like we talked about, which could lead to acute tubular necrosis. You'll see increased LFTs, which would be expected, liver function test. So like the AST, the ALT, and there is a small risk for cholelithiasis. All right, 2 down, a couple more to go. Let's talk about niacin. Niacin, what's his MOA? His mechanism of action. His mechanism of action is lipolysis inhibition in adipose tissue. He inhibits triglyceride synthesis in hepatic tissue. So, therefore, VDL or VLDL is going to decrease substantially. followed by, you tell me, followed by what? A decreased IDL and LDL. Very good. They would have to, right? Think about the pathway. Number 2, your HDL is going to increase quite substantially. Niacin is the most effective anti-lipid for elevating serum HDL levels. Remember that. And your triglycerides, what do you think they're going to do? They will go down slightly. So the big one, or the 1 and 2, the VLDL is decreased substantially and the HDL is increased substantially. So let's talk about some side effects of niacin. Side effects include flushed red face, You treat with a pre-administration of aspirin for that, by the way. Hyperglycemia, which is acanthosis nigrans. Got to speak the language, I know. And also hyperuricemia, which is exacerbating gout. Gout or precipitating gout, either way you want to look at it. So that is niacin for you. What else do we have? Resins, bile acid sequestrants. Yeah, let's talk about them. My resins. Alright. So resins, we have 3 of them. They are cholecystyrene, cholecystopol, and colcivilam. Cholecystyrene, colestipol, and colcivilam. Now, the MOA, the mechanism of action of these guys, what do? They sequester cholesterol-containing bile acids. Bile acids preventing intestinal absorption. This bile depletion increases biosynthesis, and that increased biosynthesis from hepatic cholesterol leads to a decrease in depletion of hepatic cholesterol, which upregulates hepatic LDL receptors. And therefore you get a decreased serum LDL due to its increased hepatic LDL uptake. So LDL is markedly decreased. HDL, it's kind of normal, and triglycerides are also kind of normal. normal to mildly increased. Now, some side effects of the resins. Side effects include GI discomfort, constipation, diarrhea, flatulence, malabsorption, so like steatorrhea, so you get a decreased absorption of fat-soluble vitamins, which may lead to A, D, E, and K, B12 deficiency because it's absorbed in the distal ileum. So increased levels of bile acids may irritate skin and cause pruritus. And resins or bile acid sequestrants, like example cholecystyrene, cholestyramine, colcivalam, can be used to treat pruritus in liver failure because they bind bile. That prevents the reabsorption of bile and where? The terminal ileum. That's what they mean by enterohepatic circulation. Therefore, you're going to deplete bile acid reserves, relieving symptoms of bile acid-induced pruritus. All right, and that's the resins for you. So there's one more to talk about. Hang in there. It's Sympatholytics. Sorry, I just butchered that name. Sympatholytics. What's his MOA, man? What is his MOA? He is a selective inhibitor of dietary cholesterol. Dietary cholesterol absorption in small intestine brush border. He is a selective inhibitor of dietary cholesterol absorption in the small intestinal brush border. So LDL will be markedly decreased. So if you really want your LDL to go down, what would you do? If you wanted to incrementally really take your LDL down, you use it with statins. You'll be very careful with this, though. Your triglycerides are also going to go down. Are also going to go down. There's a minimal effect when used alone, but an incremental decrease when used with statins. So statins are good drugs to combine things with. You just got to be careful about what you're doing with because of how fat soluble the drugs are. The side effects. When used alone, there's few adverse reactions, but when used in combination with statins, you get myositis, as you might imagine. It's more the statin than this. Myositis and increased liver function test. To decrease, so here we go. Here's what, if you want to, let's get us a new sheet of paper here. To decrease triglycerides, I want to do a little summary here of my hypolipidemic drugs. Summary. To decrease triglycerides, what would you use? What drug? fibrates. For the boards, you pick fibrates. Okay? Now, to decrease LDL, what would you use? Statins. Statins alone, or a combination of statin and ezetimibe. Very good. Alright, and to increase HDL, what do? What do we give them? Niacin. You got it, baby. Good job. Alright, so that pretty much covers all your cardiology drugs and what you need to know.